guys, thank you so much for joining. So my name's Samantha. I'm a locum doctor. I work part-time in general medicine and part-time in obs and gynae and sexual health. And I spend the rest of my sort of working life lecturing, editing and writing. So really pleased to have you guys here and thank you for collaborating with us. So we're going to be talking about prescribing in palliative care today. So we've got a bit of a plan. We're going to talk about some anti-emetics, some opiates, talking about opiates and renal failure, talking a bit about calculations in palliative care, a bit about drug dosing, a bit about syringe pumps, and I always like to finish my lectures with an emergency scenario just to get your heart rate up. So let's just dive in with the first question. And I'm going to give you 60 seconds to answer this question. I'd be really grateful if you submit your answers A to E in the chat box, which just gives me an idea of what answers you guys are getting. Okay, so let's just dive in with the first question. So that is a minute up. Thank you guys for participating, whether you wrote down your answer, whether you submitted that in the chat box. So let's have a think about non-pharmacological methods of relieving nausea and vomiting first. And this is particularly important in palliative care, where we've got a more patient-centered approach. So things like making sure the patient's comfortable. Often palliative care patients have a very low discomfort threshold, and that can manifest as nausea, as pain. So we want to make sure they're comfortable. We want to make sure that they've got a drink beside them, whether that be cool water, or some people prefer a fizzy drink in palliative care. It's important to think about things like removing food or food smells, as that can contribute to nausea, and instead providing small, manageable meals or snacks. Pay particular attention to what types of foods are inducing nausea. Often patients prefer carbohydrate-rich foods or salty foods, such as crisps or chips. And we want to avoid things like NG tubes and NG suction because they can make a person feel nauseous. Now, I like to think about the main causes of vomiting in palliative care with the mnemonic vomiting. So V is for vestibular causes or vertigo. So these are things like labyrinthitis, benign positional vertigo, and vestibular neuritis. O is for obstruction, and this might be a complete bowel obstruction, or it might be a partial obstruction or a pseudo obstruction. M is for medication, and that's particularly important in palliative care as most people will be on opiates. So thinking in particular things like opiates, diuretics, NSAIDs, antibiotics, these can all make someone feel nauseous. I is for infection, inflammation and ischemia. All three of these things, although treatable, can cause nausea and or vomiting. And T is for toxins, and this includes all manner of bad things in the blood, so uremia, hypercalcemia, toxic cytokines, things like that. I is for intracranial, so raised intracranial pressure, things like meningitis and things like brain tumours can all contribute to nausea. N is for nerves, so simple anxiety, and that's anxiety surrounding death or anxiety surrounding their symptoms can cause or manifest as nausea. And G is for gastrointestinal causes, which might be chemical, might be anatomical, and includes things like gastric stasis, which occurs quite commonly in palliative care. So there's lots of different receptors in different parts of the body and brain involved in producing the feeling of nausea. So starting from the top, the cerebral cortex can be stimulated by unpleasant sights, smells, or sensations. And receptors involved here are the GABA or the 5-HT or serotonin receptors. We then move down and think about the ears in the vestibular system, which involves acetylcholine and histamine receptors. Let's also think about the GI tract and input from receptors here from the stomach and the gut. And most receptors here, again, are 5-HT and acetylcholine. We then think about the chemoreceptor's trigger zone, and that's right by the blood-brain barrier. And that's stimulated by various substances in the blood, such as toxins or drugs. And they all sort of come together in the vomiting center in the medulla and produce the feeling of nausea. So this is a handy flowchart diagram from the Oxford Handbook of Oncology, which revises some of the causes of vomiting. So up at the top there, we've got things like anxiety, fear, pain, smells, and that all feeds into the higher cerebral cortex. Here we've got things like toxins, so medications, hypercalcemia, uremia, chemotherapy, things like that. That all stimulates dopamine receptors in the brain, and that feeds into that chemoreceptor trigger zone. We've also got things like vestibular apparatus, we've got raised intracranial pressure, we've got things like things in the GI tract, and we've even got things like the liver, such as capsular stretch and sort of liver diseases, things like that. And these all stimulate this vomiting center in the brain. So thinking about antiemetics, there's tons of antiemetics available, and we'll just go through each of them in turn, talking about how they act and their pros and cons. So let's start with metoclopramide. So metoclopramide has a prokinetic effect on the stomach and the small bowel, and it also acts as a dopamine receptor antagonist. So it's good for treating nausea due to chemical causes, so drugs, cytokines, metabolic imbalance, and due to its prokinetic activity, it's good for things like pseudo-obstruction and gastric stasis. In terms of side effects, it does prolong the QT, and it does have a risk of extrapyramidal side effects. So it's good for things like gastric stasis, pseudo-obstruction, and metabolic imbalances, chemical things like that. And the dose is 10 milligrams up to 4 times a day, or 30 to 60 milligrams if in a syringe driver. It also comes in a liquid form, so that's easy for patients to swallow. So let's talk about Ondansetron. So Ondansetron is primarily a 5-HT3 receptor antagonist, so that's a serotonin receptor antagonist. And it's usually used alongside administration of chemotherapy or radiotherapy, and it's good for preventing nausea. So that's why it's given alongside chemotherapy or alongside radiotherapy. The downside of Ondansetron is it is constipating, and it slows down digestive transit in most people. So it's good for sort of chemotherapy along with chemotherapy, but it doesn't seem to work as well for delayed onset chemotherapy-related nausea. And the dose is 4 to 8 milligrams orally, so twice daily or 3 times daily, or 8 to 24 milligrams over 24 hours if in a syringe driver. So Domperidone, so that acts similarly to metoclopramide, as it's a dopamine receptor antagonist and a prokinetic. The advantage of Domperidone here is that it doesn't cross the blood-brain barrier, so it's got less risk of extrapyramidal side effects. So it's good for patients, again, with gastric stasis, and it's good for patients that are at higher risk of side effects, so those with Parkinson's or things like that. And the dose is 10 to 20 milligrams orally, 3 times a day or 4 times a day. So moving on to cyclazine. So cyclazine has both antihistamine and anticholinergic effects. It acts to reduce excitability of the inner ear and also acts centrally at that vomiting center that we spoke about. So it's good for vestibular causes or motion-induced nausea, and it's also good for central causes like raised intracranial pressure. And we can also use that in things like bowel obstruction. It is anticholinergic, so we do get those classic side effects of a dry mouth. That can also extend to urinary retention. And the dose is 50 milligrams orally 3 times a day, or 100 to 150 milligrams over 24 hours subcut, depending on what they've been taking orally. So let's think about hyoscine. So hyoscine is another anticholinergic. So it blocks acetylcholine receptors in the gut, vestibular system, and the vomiting center. Therefore, it's good for a few things: movement-related nausea, gut-related nausea such as obstruction, and again, we've got to think about those side effects of sort of a dry mouth and restlessness. The hyoscine is also used to its advantage in palliative care because it tends to dry up mouth secretions. So if a patient's struggling with sort of noisy breathing or wet breathing, hyoscine has that dual effect of drying things up as well as providing anti-emetic cover. It can be given sublingual, and it can be given as a syringe pump. Moving on to haloperidol. So haloperidol, again, is a dopamine receptor antagonist, and it's got other actions. It's a bit of an antipsychotic. It can help with things like hiccups, which are surprisingly common in palliative care, and it can help with things like antipsychotic things and anti-anxiety. So again, it's an antidopamine drug, so we've got to watch out for those extrapyramidal side effects. Haloperidol is good for things like chemical toxicity, and it's often used if a patient's nauseous but also anxious. And we've got to bear in mind that the potency of it, if you're given subcut, is 2:1. Moving on to levomethomazine. So levomethomazine is a bit of a dirty drug. It acts at lots of receptors, and for this reason it's often used in palliative care where it's not clear what the cause of nausea is. So maybe a patient's been given some chemotherapy, maybe they might have a bit of a pseudo-obstruction, there's lots of reasons for their nausea. Levomethomazine does hit lots of receptors. And it's also good for things like anxiety and does provide a bit of a sedative effect. The dose there is 6.25 to 25 milligrams once a day, or it can also be given as a syringe pump. And the last drug I'd like to talk about is plocarperazine, which is which is often referred to as Stemetil or Bucostem, and it's useful for motion-related nausea. Again, we've got to watch this because it does prolong the QT and it does have a sedative and anti-anxiety effect. So it's good for things like movement-related nausea or dizzy-related nausea. And it can be given buccal, oral, or it can also be given in a syringe driver. So it is quite confusing when you've got given a huge list of antiemetics and you're not sure what to use. So in summary, you do have to think about why the patient is nauseous and consider the effects and side effects of each drug. In general, for chemical toxicity, so drugs, metabolic, biochemical, we tend to use a dopamine antagonist because that hits that central receptor zone. So we're thinking about things like metoclopramide, domperidone, or haloperidol. And these hit that chemoreceptor trigger zone. So they're useful for quite a lot of causes of nausea. If you're worried the patient has a motility disorder, so if they've got gastric stasis, or if they've got pseudo-obstruction, you might think about using an antiemetic with prokinetic properties, so metoclopramide or domperidone. However, in confirmed bowel obstruction, we want to avoid prokinetics as they can stimulate the gut and can risk perforation. So if someone's got, say, no bowel sounds or no flatus, you'd worry about using a prokinetic in that situation. And instead, we'd want to use something to dry up secretions. So something like an anticholinergic like Hyoscine would be good. For raised intracranial pressure, that's almost always treated with a steroid plus cyclizine. If someone has movement-related or a vestibular cause of nausea, we want to think about anticholinergics or antihistamines. So things like cyclizine, Hyoscine, and prochlorperazine. For post-op nausea and vomiting, we generally use Ondansetron. So that, remember, that's a serotonin receptor antagonist. Ondansetron tends to be used quite a lot for the prevention of nausea and vomiting, both in surgical procedures and is often given alongside chemotherapy. But it doesn't tend to be very good for when the patient's already developed nausea after chemotherapy or after surgery. So it doesn't tend to be used for kind of delayed onset nausea. And if you've no idea what's going on and you don't know why your patient is nauseous, like I said, levomethomazine is a good shout. Like we discussed, it hits a few different receptors, so that will work for many causes. So let's just check back with the question, and thank you for those who have submitted an answer. So this woman has a chemical toxicity. She's been given chemotherapy, and that's likely what's making her nauseous. So as we've gone through, the first line antiemetic for a chemical toxicity is a dopamine antagonist. And the first line dopamine antagonist we tend to use is metoclopramide. She might also have an element of gastric stasis. So again, metoclopramide might help with that too. Let's look at the other answers though, because I know some of you submitted different answers. So let's look at ondansetron. So ondansetron is a 5-HT serotonin antagonist, and it's often used at the time of chemotherapy for prevention. But as I mentioned a couple of times, it's not great for treating delayed onset nausea and vomiting, and has the added side effect of making someone constipated. Thinking about cyclizine. So cyclizine, remember, that's an antihistamine and anticholinergic. So it's better for things like vestibular causes, intracranial causes, and motion-induced causes. So cyclizine is probably not going to work for us here. And prochlorperazine, that's a dopamine antagonist. So that is what we're looking for, but that tends to be quite sedating, so we don't use that first line. And hyoscine, that's an anticholinergic. So like, remember we talked about obstruction, secretions, movement-related nausea, and it definitely causes a dry mouth in most people that take it. And the scenario actually says she has a dry mouth, so we'd want to avoid that. So the single best answer here I've chosen is metoclopramide, and we give that orally because she's not actually vomiting at the moment, so we're fine to give something orally. So let's move on to the next question, and again I'll give you 60 seconds to have a read at the question and submit an answer if you want to. Feel free to submit an answer in the chat box. Lovely, thank you so much for those that submitted an answer there. So this lady's approaching the end of life, and it's sensible to set up a syringe pump for this patient. So let's just think about, first of all, about calculating opiate requirements. So to calculate the requirements for a syringe driver, we need to calculate the total dose of morphine used over the previous 24 hours. And this includes both regular morphine and any PRN or as required morphine. And we prescribe this by syringe driver over 24 hours. And pain that occurs despite a regular opioid requires breakthrough medication. So that's treated with an immediate release formulation, and we normally give that at a dose of 1/6 to 1/10 of the total 24-hour dose. So this table is from palliativedrugs.com, but there's similar conversion tables available in the BNF. So when converting opiates, we always start with the oral morphine dose, and we can then convert that to any other drug that's listed in the table. So let's just have a look at our question here and we'll dissect that together. So in this case, the patient is on 40 milligrams of oral morphine twice daily. So she's on 80 milligrams of regular morphine. And she's also used 40 milligrams of breakthrough morphine. She's used 4 doses of 10 milligrams. So she's got 40 milligrams of breakthrough morphine. So therefore, her total daily dose of morphine is 120 milligrams. And we're being asked here to convert that to subcutaneous dose. So if we go back to our conversion ratios, it's a 2-to-1 ratio to convert oral to subcutaneous. So we want to convert 120 milligrams into a subcutaneous dose. So she should be prescribed 60 milligrams of subcutaneous morphine over 24 hours. And remember that she needs a breakthrough dose as well. So to calculate an appropriate dose for breakthrough pain, we divide that total daily dose by 6. So here we're dividing 60 milligrams by 6, which gives us a breakthrough dose of 10 milligrams. So I hope that makes sense in terms of opiates. Let's think about her cyclizine. Now, she's not actually used her cyclizine in the last 24 hours, so it's sensible to keep that as an as-required medication. We wouldn't want to take that away completely, but it sounds like she's not actually needing that right now. So the correct answer here is B, subcutaneous morphine, 60 milligrams over 24 hours with a breakthrough of 10 milligrams as required. And we keep that cyclizine as a subcutaneous dose of 50 milligrams as required. And we've got the correct up to 3 times per day. So in terms of calculating these things, always be careful to check and double check any conversions. And remember that the subcutaneous dose should always be half of the oral dose. So if we look at the other answers there that are available, A is not correct because we've forgotten to divide that oral dose by 2 to give the subcutaneous dose. C, I've put that as not correct because we've left out the cyclizine. And what if this woman gets sick in the middle of the night? You're going to have to go to the ward and prescribe her cyclizine again. D is not correct, as we've forgotten our conversion ratio and we've also forgotten the cyclizine. Thinking about E is the correct opiate dose, but this time we've included cyclizine in the syringe driver. There is a bit of clinical judgment here, so generally we wouldn't put something in a driver that the patient hasn't been needing because all we're doing there is introducing side effects. However, if this patient had been using cyclizine every day for the past few weeks and it just so happened that in the last 24 hours she didn't need it, you might consider adding that into the syringe driver. But given the information in the question, she's not needed it, so I've not included it in her syringe driver. And just remember that cyclizine does have side effects. It's got anticholinergic side effects. And cyclizine quite often causes a nasty reaction at the subcutaneous insertion site. So we tend to try and avoid putting things in patients that they don't actually need. So the correct answer here is B. So let's move on to the next question. Again, I'll give you a few seconds. I'll give you 90 seconds to read the question and please submit an answer in the chat box if you're okay with that. Great, thank you very much for participating there. So let's just dissect this situation here. We've got an elderly man who's got cancer, he's a bit dehydrated and he's not feeling great. And hopefully we've all realised that he's got quite a significant renal impairment. So this question is really asking, what do we do when someone's on opiates and they've got renal impairment that we didn't know about? So we need to decide which opiate is most appropriate for him. So let's think about opiates in renal failure and what is the most appropriate opiate for someone with renal failure that's approaching the end of life. So morphine isn't really suitable in renal failure. It's excreted via the kidneys and it's likely to build up into toxic doses in someone that's got renal failure. Oxycodone can be used in mild to moderate renal failure as it's mostly metabolized in the liver, but we'd aim to avoid that in severe renal failure, especially in someone whose renal failure is getting worse. Fentanyl is mainly metabolized in the liver, and it's useful for patients with stable pain as it can be delivered through a patch. We wouldn't normally switch to a patch at the end of life because patches are better for stable pain and they can't be titrated as rapidly as kind of a subcutaneous or an IV dose. Alfentanil is our go-to opiate for patients with renal impairment who are requiring a syringe driver. It can be titrated and it's okay to use in renal failure. Diamorphine, again, that wouldn't be suitable as again, it's excreted through the kidneys and it can damage the kidneys and cause toxicity. So let's just go back to the question here. And I think we've decided this man needs a syringe driver and the most appropriate regime would be alfentanil. This is one of the safest drugs to use in renal failure. Let's check with the other answers. So why wouldn't we use just a reduced dose of morphine? Well, for a start, I'm not sure if this man's going to be up to taking tablets. It sounds like he's approaching the end of life. Also, we don't know where his renal failure is heading. Is it going to get worse? Is he going to accumulate opiate and become toxic? And so why wouldn't we use a syringe pump with morphine? That's for exactly the same reasons. Morphine can accumulate and cause him to become opiate toxic. I noticed a few of you put the answer C. Why wouldn't we go for a fentanyl patch? Sorry, answer D. So why wouldn't we go for a fentanyl patch? So when we're switching to a patch, normally we allow some overlap, just so the patient's not in pain at any point. Unfortunately, with a patch, we're not able to titrate the pain relief as easily. So patches are not usually introduced at the end of life in this sort of situation. In terms of oxycodone, I think a few of you put oxycodone. That is okay to use in things like moderate renal failure, as it's less toxic to the kidneys. But again, we don't know how this man's renal failure is going to progress. And is it fair to be taking bloods from him to monitor his U's and E's? A syringe driver allows for greater titration and we don't need to worry about him taking tablets. So I think the only sensible answer here is subcutaneous alfentanil. So I'm going to move on to the next question. And again, you'll have sort of 90 seconds to submit an answer into the chat box. So thank you guys who've submitted an answer there. So you might have noticed I deliberately left out any doses in the last question. But of course, when you're working as a doctor, you not only need to know what opiate is most appropriate, but you're the one that's prescribing it as well. So let's think about conversions to alfentanil. So we've decided that alfentanil is the right drug, but how do we convert his doses to alfentanil? And this is the same table that I've got from palliativedrugs.com. And again, there's similar tables in the BNF. So again, just to recap, when converting opiates, we start with the oral morphine dose, and we can convert that to other opiates as per the table. So let's check back with this man. He's taking morphine sulfate modified release 20 milligrams twice daily. So that's 40 milligrams. And he's also used 2 doses of 5 milligrams in the last 24 hours. So that's an extra 10. So his total oral morphine dose is 50 milligrams. And we've already decided on subcutaneous alfentanil as the drug of choice. So we need to convert this total daily oral morphine dose of 50 milligrams into a total daily dose of alfentanil. And if we check with the table here, we can see the conversion factor is 30 to 1. So this means we've got to divide the oral morphine dose by 30, and this gives us the alfentanil dose. So if we divide 50 milligrams by 30, that gives us 1.66666 milligrams of alfentanil, or 1,666 micrograms. And remember, the question told us that alfentanil comes in 2 milliliter ampules, which contain 500 micrograms per milliliter. So bearing that in mind, we have 2 milliliter ampules containing 500 micrograms per mil. We're going to choose a sensible dose, as close to the calculated dose as possible. It's going to be impossible to draw up 1.66 of a drug, so we choose the nearest acceptable dose. So we're going to go here with 1,500 micrograms or 1.5 milligrams. And therefore we're going to require 3 mils, which is 1.5 ampules. So let's think about breakthrough. And we can see the total alfentanil dose is going to be 1,500 micrograms. So breakthrough, remember that's always 1/6 of the total daily dose. So that will be 250 micrograms. There's a couple of ways of kind of calculating breakthrough dose. We can go back to think about the total daily dose of oral morphine. So if we go back in that way, it's a bit of a roundabout route, but we get to the same answer. So the total morphine dose was 50 milligrams. The breakthrough morphine dose, therefore, is 1/6 of that, which is 8.3 milligrams. And if we convert that to alfentanil by dividing by 30, that gives us 0.2 milligrams or 277 micrograms. And again, we'll pick a sensible dose here. We can't draw up 277 micrograms. So we'll pick a sensible dose of 250. So checking back with the question, the correct answer here is E, 1,500 micrograms over 24 hours with 250 micrograms as breakthrough. Let's check with the other answers here. So the answer is not A, as this PRN dose is too high. We got to a figure of 277 micrograms when using the oral morphine to calculate the breakthrough, but we tend to round down with opiates. We always err on the side of caution to avoid toxicity. The answer is not B, as this is a factor of 10 out. Remember that 1 milligram is equal to 1,000 micrograms. The answer is not C, as this is the wrong units. Please be mindful of this in your exams, especially for those that have still to sit the PSA exam. They quite often have answers that try and catch you out like this, so please be mindful of the units. The answer is not D, as we wouldn't prescribe these sort of silly doses. It's too difficult to draw up these doses accurately, so we do round to the nearest sensible dose. And a little note about prescribing when you all become doctors. It's fine to write mg as milligrams, but it's good practice to write out micrograms in full rather than writing mcg, just to avoid any prescribing errors. If it's misread, you could be out by a factor of 1,000, which could be dangerous. So I hope that makes sense. We're going to move on to the next question. And again, I'll give you 90 seconds to read the question and submit an answer into the chat box. Thank you for participating. So here we've got a woman with cancer and she has back pain. And we've got a note of what drugs she's taking, but of note she's taking 50 milligrams of oxycodone modified release twice daily. So that's 100 milligrams per day. And she's also using quite a lot of breakthrough. So she's using 5 milligrams between 8 and 10 times per day. So again, that's another 40 to 50 milligrams. So thinking about this question, first off, the palliative care guidelines suggest that breakthrough analgesia should be used no more than 6 times in a 24-hour period. So this is an indication that this woman does not have adequate background analgesia on board. But let's calculate her total daily dose. So she's got 100 milligrams of background long tech, and she's using 40 to 50 milligrams of breakthrough. So her total daily requirements are between 140 and 150 milligrams per day. So we should consider changing her background long-acting opiate to reflect that. The guidelines also specify that when we're increasing the regular dose, we should also increase the breakthrough dose. So let's just do some prescribing here. So we know that her total background dose is 140 to 150 milligrams twice daily. So let's prescribe 70 milligrams BD, and that gives us her 140 per day. And let's think about breakthrough dose. So we always prescribe a 1/6 to a 1/10 of her total daily dose. 1/10 would be 14 milligrams and 1/6 would be 23-ish milligrams. But let's prescribe a sensible dose. Let's prescribe 15 milligrams. And again, we always err on the side of caution when we're changing opiate doses. So we tend to round down rather than round up. She can always use more PRN, but if we make her opiate toxic, we are in trouble. So the correct answer here is C, 70 milligrams of long tech, the long-acting oxycodone, with breakthrough of 15 milligrams. So the answer is C. Let's check with the other answers though, because you did have some mixed responses there. In A, we've left her regular opiate as it is, and instead we've increased her breakthrough dose. That's a risky move because she's currently taking 8 to 10 tablets a day as breakthrough. So she's at risk of her total daily dose being way higher if she continues with 8 to 10 tablets a day and we increase that to 20. We always increase background analgesia first to reflect that total daily dose, and we adjust the breakthrough analgesia accordingly. So in B, we have increased her regular opiate, but we've left her breakthrough at 5 milligrams. While this is less dangerous as A, it might not offer her effective analgesia, and we always put the breakthrough as 1/10 to 1/6 of the total daily dose. In D, we have increased her regular opiate by too much. So this is double her dose just now. So she is needing 70 milligrams BD because she's needing 140 in total. So 100 BD would be 200 over the course of 24 hours, which would be far higher than what she's needing. In E, we've completely changed over to morphine. And remember the conversion from oxycodone to morphine. Oxycodone is twice as potent as morphine. So in E, we have converted this correctly, but we wouldn't normally be switching opiates for no apparent reason. It's also worth noting in this question, this patient is on whacking doses of opiate. So we might want to consider things like alternative forms of analgesia. She's not even on anything like paracetamol, and she might benefit from things like a lidocaine patch onto her back as a sort of local pain relief. Also to note in this question, there's lots of distracting information, and this quite often comes up in exams. Really, all it's looking for you to do is to perform an opiate calculation, but it's giving you things like trastuzumab, tamoxifen. Please don't worry about not knowing what these drugs are or how they interact. It's simply trying to distract you. So well done for you guys that ignored all that nonsense that we don't need to know and just went on with the opiate conversion. So we're going to move on to question 6, and again, I'll give you a minute to read the question and submit an answer into the chat box. You might benefit from access to the BNF for this question if you have that on your phone or if you have a paper copy. So thank you for submitting answers there. So let's check with the BNF for enoxaparin. So if we look at the BNF here, we can see that there's guidance for the scenario of pulmonary embolism in patients with risk factors. And that covers this patient. She's got cancer and she's symptomatic. And it specifies a dose of 1 milligram per kilogram every 12 hours. So checking back with the question, we're given the patient's weight of 58 kilograms. So therefore she needs 58 milligrams every 12 hours. But enoxaparin doesn't come in 58 milligrams, does it? So again, we round to the nearest sensible dose. And we can see here, we can get enoxaparin in a 60 milligram injection. In these cases, it's okay to round up to a close, sensible dose, because if we rounded down to 40 milligrams, she might not get an effective anticoagulant effect. So there we can see the correct answer is C, enoxaparin 60 milligrams twice daily. So I think most of you got the correct answer there. Well done. And just so we know, if you guys haven't done the PSA, the Prescribing Safety Assessment yet, to get familiar with these online versions of the BNF. So I think in the PSA, you get access to the medicine's complete version. And I encourage you to practice using the search function or the find function. So that's Control F on a Windows computer. That will allow you to quickly jump to relevant information. So you can see here in this screenshot there, I've searched for the term pulmonary embolism and I've jumped straight to treatment of pulmonary embolism. So it's taken me literally seconds to get to the right answer there and to be able to get to the right part of the BNF. So definitely practice searching for things and practice using the Control F function. That does work in the PSA. So let's move on to the next question here. And again, I'll give you a minute to answer the question. Thank you for submitting answers. So we've been asked to make up a syringe pump that's already been prescribed. So let's take midazolam first. We're asked to prescribe 10 milligrams of midazolam. Each 1 milligram contains 2 milligrams. So we were going to need 5 milliliters, which is 5 ampules. Having a look at morphine, we've been asked to prescribe 40 milligrams of morphine. Each 1 milliliter ampule contains 10 milligrams. So we're going to need 4 mils or 4 ampules of morphine. So therefore, our total volume of actual drug is going to be 5 plus 4, which equals 9. And in the question here, we're asked to make this up to a total volume of 48 mils. So if we take 48 mils minus our drug volume of 9, we get a water volume of 39 mils. So we need 39 mils of sterile water. Now, you'll rarely be asked to make up syringe pumps as an FY1. You're more likely to be asked to prescribe things for it. The nurses are generally pretty good at making up syringe pumps. But as part of your foundation year 1 competencies, you are required to make up some drugs. So you will need to do this at some point. So checking back with the question here, the correct answer is C, 39 mils. And I think all of you guys got the correct answer there, so well done. Just to alert you guys, this question has quite a lot of distractors. So this is when you get more facts and figures than you actually need to know to complete the question. So this question is a good example of distractors. It's telling you about ampules and how many milligrams and mils each ampule contains. That's pretty irrelevant for this question. All we need to know is the actual doses. So it's pretty common as well that syringe drivers are not made up to the full volume. Quite often, if it's a 50 ml syringe, the nurses will make it up to 48 or 46 mils. So that's quite common. But you guys all got the right answer there, so well done. So let's move on to the next question. Again, I'll give you 60 seconds to answer the question and submit an answer into the chat box, please. Great, thank you for your calculations there. So this is a favourite question asked by anaesthetists to unsuspecting students or FY1s. So first we've got to calculate the maximum dose allowed for this patient. So we're already told the maximum allowable dose is 4.5 milligrams per kilogram. So for this patient, it's 64 kilograms. The maximum dose is 4.5 times 64, which is 288 milligrams. We've then got to think about the formulation of lidocaine. So we're told it's 2% lidocaine, and that means that there's 20 milligrams of lidocaine in 1 milliliter of solution. So if there's 20 milligrams in 1 mil, then 288 milligrams is 288 divided by 20, which equals 16.875. So the maximum volume of anaesthetic allowed is about 16 mils, or about 8 vials. Oh, sorry. In practice, if you're getting to using your 8th vial of local anaesthetic to put in a PICC line, you should probably be worried anyway. So I realise a few of you guys had submitted the answer B of 14 mils. The correct answer there is going to be 16 mils because it's 288 milligrams and it's 2% lidocaine. So there's 20 in each mil. Yep, which equals 14. Yep, you're right. So let's move on to the next question. And I like to finish each sort of lecture with an emergency scenario. So just to get your heart rate up, make you a little bit scared, I'll ask you to read this emergency scenario and to submit an answer. So thank you for submitting an answer there, guys. So this is an absolutely horrendous situation that happened to a colleague of mine. So here we've got a youngish man who's had fairly radical treatment of some sort of head and neck cancer. He's gone through surgery, he's had chemotherapy, he's had radiotherapy, but unfortunately his cancer has returned. And we're being asked to see him in the most horrific of circumstances. He's essentially exsanguinating from his oropharynx, which is manifesting as massive either hemoptysis or hematemesis. We're not even sure, there's so much blood. There's blood everywhere, and everyone, including the patient, is in a panic. So this is what we would call a massive terminal hemorrhage, and is a horrendous situation to find yourself in. And although rare, it does happen. And it typically happens in patients that have had head and neck cancers. And in this case, it's likely to have occurred due to direct invasion of the carotid artery. And this has resulted in an unsurvivable hemorrhage. So if we have a look at the palliative care guidelines, this gives us some guidance on what to do in this situation. And the first thing to do is remain calm and remain with the patient. If we can put pressure on the bleeding area. In this case, there's not much we can do. It's clear in this case resuscitation is not appropriate, so we need to think about if we can offer some pharmacological management to ease this man's distress. The guidelines suggest using a rapid acting benzodiazepine via whatever route is available. And this man's already got IV access, so we can use IV midazolam. If the IV route wasn't available, we can use the intramuscular route, and we're aiming to provide rapid sedation for the patient. The patient is going to die in this situation, but we're trying to help them die more peacefully. So the correct answer here is C, to administer 10 milligrams of IV midazolam. Let's just have a wee look at the other answers that we might be tempted to choose. So if we look at A, administering blood, blood's going to take too long to arrive, and this man's going to be dead by the time it's in its body. Thinking about IV morphine, so IV morphine will probably, 50 milligrams will probably knock him out, but that dose won't feel particularly nice to receive, and it might result in further vomiting or other adverse effects. That's also not a licensed dose as a stat dose, and morphine shouldn't be used in this way. IV midazolam acts as an anti-anxiolytic and a sedative. So hopefully our aim here is to sedate this man to a point where his distress is alleviated. Looking at D, administering a fluid bolus, that's not going to do much to replace this person's ongoing losses. And tranexamic acid, that's not going to work right away, and that patient's going to be dead by the time that's in his body. So just to summarise what we've been through here, we've gone through antiemetics, opiates, calculations, a bit of dosing, syringe pumps, and we've gone through an emergency. I'm just going to have a wee look at your questions and answers and see if I can answer as much as possible. So I'm mindful there that one of the questions was incorrect. So let me just go back to that. So you're absolutely right here. The correct dose here was 14 mils because 2.88 divided by that is 14. So I'm sorry, the answer there was incorrect. You're absolutely right in what you guys had said. A few of you have asked about how do we calculate breakthrough doses? Do we use 1/10 or do we use 1/6? The BNF gives guidance of using anywhere from 1/6 to 1/10. So it's a bit of clinical judgment and a bit of choosing a sensible dose. So we talked about using a sensible dose that can actually be drawn up. We don't tend to use 0.000 or silly doses that we can't draw up. So it's a bit of clinical judgment whether we go on the side of 1/6 or one side of 1/10. The BNF sort of gives us a range, which is sometimes not particularly helpful. Let me just have a wee look at your other things. So in this question here, someone is asking there, why are we giving midazolam in preference to lorazepam? In this question, simply because lorazepam is not an option. But lorazepam is an absolutely valid anti-anxiolytic and sedative for use in palliative care and palliative care emergencies. We're not using lorazepam here simply because it's not an option. So in single best answers, sometimes the answer you want is not there, and you're used to asked to pick the single best answer. Let me just check if there's anything else I can answer. Someone is asking, why don't we use a syringe driver in renal failure? We do use syringe drivers a lot in renal failure and palliative care. What we don't use is patches. because patches, they're not very easy to titrate, and they're not very easy to know how much is getting into the system, and someone can easily become toxic with a patch. So we tend to err on the side of syringe drivers in renal failure and palliative care rather than patches. But syringe drivers are absolutely the way to go in all palliative care patients with or without renal failure. So thank you everyone for answering your questions and participating. Just to remind you, we've got a special Quesmed offer on. So for everyone who fills in the feedback form, you'll be entered into a draw to win 1 month of free Quesmed subscription. So that involves all lectures, all question bank answers, questions and answers. So that's a really, really good offer. So I definitely encourage you guys, take 2 seconds to fill in the feedback form. Let me know your thoughts, and hope to see you again in another Quesmed lecture. So thank you very much for hosting us.